Hi, my name is Jeff Sparks. Welcome to ACR 24, and I am really glad to be joined by Dr. Scott Matson from the University of Kansas, a pulmonologist here who gave an invited talk on abstract 17S14. This was about treatment considerations for RA-ILD. This was an incredible talk. It was standing room only, and actually the overflow room was also completely filled, so a lot of interest in this topic. So first, I wanted to see what are the most recent advances in the treatment for RA-ILD?
Yeah, thanks, Jeff. It's a great question. What our group's been focused on is how we can best understand the kind of individual patient factors for patients who have RA in terms of what about their ILD can help us understand how they may respond to available treatments. And I think there's been a paradigm in the pulmonary field, certainly, where we think about these patients as either having a fibrosis predominant ILD or a more inflammatory patterned ILD. And so what we presented today was from data from our group where we've looked at treatment outcomes for patients with RA-ILD who were started on immunosuppression. And we looked at a few different things about those patients. So we looked, first of all, at the overall outcomes. And what we see is that these patients generally do worse before they get this directed ILD immunotherapy. And then at the time of immunomodulation initiation for these patients, they have stabilization of lung function. And what we talked about today was some secondary analyses from that outcome, where we looked at patients who had RA that had a UIP pattern, the more fibrotic pattern ILD, compared to those without. And what was interesting in this data set is that these patients with UIP who had the more fibrotic patterned ILD actually had a numerically greater improvement in their FVC trajectory when compared to the non-UIP group. And we followed that up with some quantitative CT analysis of the same cohort. And what we see in that analysis too is that the degree of fibrosis and the degree of ground glass, even though the paradigm is sort of that it's only those patients with more ground glass and less fibrosis that we think we should potentially only treat those patients with immunomodulation, in our analysis, it's essentially all negative data. And so I think what this means is that there's a lot of questions still about which patients with RA-ILD will respond to immune suppression best, but at least as of now, it seems like radiographic pattern and the way we define fibrosis on these CT scans is probably not the full story there, and those patients may still have a positive response to immune suppression.
So you had given some data that many different immune suppressants seem to stabilize the disease course. Could you tell us about what if patients continue to progress, and when would you consider getting antifibrotics in the mix?
Yeah, it's a good question. So the data that we looked at was a real-world observational outcomes of patients who had been on rituximab, azathioprine, or mycophenolate, and that was immunotherapy that was started to target the ILD. And I think in the real world what we see is that a lot of times even when you start that kind of therapy, patients continue to progress. And I think what we know from the Trail 1 investigators and antifibrotics and RA-ILD is that it's safe to add antifibrotics to these patients and that it does have meaningful improvements in FVC change when compared to placebo. So I really don't hesitate in the real world to trial patients who are progressing, who have fibrosis, on antifibrotics, because you can continue to alter immune suppression in the background. And if a patient can tolerate it, it does seem to probably have meaningful outcomes, especially if you imagine that carried forward beyond 1 year.
Sure. So you're a pulmonologist here at a group of many rheumatologists. Yeah. I'm curious from your perspective, do you have any advice about practicing rheumatologists when they find RA-ILD, how would they best co-manage the patient with a pulmonologist?
Yeah, it's a great question. I think that bringing together these two fields of expertise in terms of how frequently we should monitor it, in what ways we assess disease progression, and then I think it's just really about this kind of collaborative care. A lot of times there's so many variables we have to adjust that if you can be on the same team and time some of those adjustments so that if you're adding an antifibrotic, it's not at the same time as you're altering immune suppression. In those scenarios, you can maybe better tease out in that individual patient which patient's responding and which patient's not. Yeah.
And I'd say, in closing, it's incredible how little data we know. There's only been one dedicated RA-ILD trial, and in fact, there's probably less than 300 patients who've ever participated in a randomized trial for RA-ILD. So there's really a lot of opportunity, despite it being our most common disease. And there's already been other abstract sessions. There's another session about lung disease tomorrow. So this is definitely a topic that there's a lot more room for growth. So thank you very much for your interest in our field, and I look forward to continue collaborating. So thank you again for your attention, and we'll look forward to our next videos at Room Now. Thank you.